Good morning, everyone. We'll go ahead and get started. I'm sorry for the late start this morning. Happy Friday, everyone. And I'm glad that you're here. So thank you for coming out. My name is Angelica Ortman, and I will be assisting throughout the day with the training. And I also want to give a special thank you to PRMC for hosting our training session today, and especially Bob Lanza for helping to coordinate that. Let's see. So there are a couple of things that I want to go over with you today before we get the training started. First and foremost, if you do need to use the bathroom, please feel free to get up whenever. We do have a long day today. We are scheduled to go till about 4:30. Hopefully we can get out a little bit sooner than that. But if you do need to use the bathrooms, the women's is straight out the door to the right, and then for the men's, it's just straight out the door to the left. For the training, it is going to be recorded so that folks can access it later on. We'll actually be recording, as you can see, with the video camera, and then also we will be recording the audio and also the slides. So everyone should be able to have access to the slides and the actual audio that's taking place today. And once that's ready, we'll send out an email link to everyone so that they can access that. Now, a couple of things also, if you need to use the Wi-Fi, you just connect to the guest and then it will walk you through on how to log in. I think you have to give your email address and then you should be able to use that throughout the day. And hopefully everyone sat where there's a folder. If you don't have a folder, please let me know or grab one that's closest to you. So there's a couple of documents in there that were not sent in the reminder email. So the reminder email that was sent out yesterday actually has a link to all the PowerPoints that we'll be going over today. But as far as the items in the agenda, there's 3 documents that I wanted to go over with you really quick. So the first one is the agenda. So the agenda actually outlines, let's see, where is it at? Looks like this. It actually outlines the sessions that will be going on. We have about 11 sessions taking place. There's also some scheduled breaks in between, and should have been advancing this. We also have a break for lunch at about 12:25. Lunch will be coming in at 12, and they'll be setting up over there in the corner. Let's see, the other document I wanted to go over is the training action plan, which looks like this. It's a 1-pager, front and back. This is broken out based on the sessions, also based on the MDPCP requirements. So if you are listening to things and you want to take notes, any type of follow-up items based on the session, this is here for you to use as note-taking. Okay, and then the last document that I want to go over in the folder is titled the pre and post survey, which looks like this. And this document is really helpful for us to evaluate the training content that's being delivered to you today. So we want to make sure that the information is applicable to you as you are attending these sessions. And also, it also gives you an opportunity to provide comments on what you would like to see in the future for training. So the way that the pre and post survey work is before each training session, we'll ask you to take the pre-survey. And depending on the session, there could be one question specific to the topic that's being presented. There could be more than one question. But if you take a look at the first one for the first session, it's rating your level of knowledge from a scale of 1 to 5, with 1 being the lowest level of knowledge that you have, and 5, being the highest level of knowledge, and you should actually be up here speaking and presenting on it if you are a 5. But just an example, it says for the first one, rate your level of knowledge on the Maryland Primary Care Program framework. So before the session, you would just click, or you would just circle or X the number. After the training content is delivered, then we'll ask you to take the post survey so you can rate your level of knowledge on the information that was given. So I know that's a long day. If you do have to leave and you can't stay, just please, if you can leave your surveys on the desk, or if you can come up here and just leave it on this front table, that would be great. And I want to thank you in advance for filling that out. Okay, so there's a couple other documents in the folder that we'll hit on as the training sessions go on. The other thing are the different breakout sessions that we'll have throughout the training session. So we definitely want to make this interactive and learn from others' experiences. So for the breakout sessions, we may ask that you share your experiences with certain topics that are being presented. We also have the ability, if you want to participate in an interactive poll. So if you do, some of the interactive polls, you will have to either go on the website to participate, or you can have the ability to be able to text and participate that way. So we'll definitely let you know which option you would have to do when the interactive poll comes up. But if you want to right now, if you want to text, you could definitely do that now. There's information on the desk, the little paper that shows what you would have to text in. And if you do that now, that will actually send you a welcome text, and then you'll be able to just participate throughout the day when those polls come up. If you have any questions about that, feel free to come to me and I'll assist you with that as well. Okay, the last thing is the CME and the CEU credits. So this training activity was actually approved for 7 AMA PRA Category 1 credits, being AMA being American Medical Association. And so, you know, you're probably sitting there, I think there was like one physician that signed up, but these credits are also applicable to non-physicians as well. So after the training on next week sometime, you'll receive a follow-up email with instructions on how to apply for the credits. So for non-physicians, what you'll get is a certificate for participation, and then what you would have to do is just go to your credentialing agency and see if they will accept the credits, and most of them do, but you definitely want to confirm with them if they are going to accept the credits or not. Okay, so that is all for the opening remarks. Again, if you have any questions, feel free to stop me during the break or anything like that, questions or concerns. And without further ado, I'll introduce our first speaker, Dr. Nkem Okeke.
Dr. Haft expresses his sympathies here. He had wished to be here to do the first session, but he had to go to Tennessee. So I'll be standing in for him for session 1. So let me start by saying good morning. Good morning. I am Dr. Nkem Okeke. I'm a primary care physician by trade, but I no longer practice clinical medicine. But I since then moved on to public health and business healthcare administration. In the past decade, I've been supporting payers and providers in better understanding how to engage and collaborate better to improve population health. Most importantly, I was a faculty lead for CPC Plus, which is the national version of MDPCP. So I've been supporting Dr. Haft and his team from the very beginning. So hopefully myself and my team can be able to walk you through the MDPCP program and the model and kind of brainstorm what you're thinking, share ideas of what's working, and we'll do our best to kind of give you something to walk away with. Tips, ideas, again, there's no one way to do this work, but we can at least give you some more hands-on learning experience and examples that you can at least build on. Okay, that's me. I have no disclosures related to this presentation. So the training is designed actually for practice staff, so those who support the practitioners. We're working on a training that's specific to practitioners that will happen later in the year. And this is because we understand that as a leader, you make decisions, and it's one thing to kind of have the practice staff trained, but it's also good to train up the practitioners so that you can all be in sync. However, some practitioners wear multiple hats. They are administrators some days as well as clinical leads. So if you have practitioners in the room, that's also helpful that you get to hear what everybody's listening to on your team, so that way you can work together better. So an icebreaker. I love the setup in the room. So I want to start by saying that this takes team effort. It takes teamwork, both in your immediate practice all the way up to the state and then CMS. So I want to encourage us to believe that we have strength in working together. So if everybody could please stand up and give at least 3 people a high 10 and say, we're in this together. I'll start with you. We're in this together. Great. So when you're having a bad day, when you're asked to send the patient roster and giving you a hard time, and all the different challenges that you will go through, remember, we're in this together. Call a friend, go for coffee, happy hour, on the hour. Okay, awesome. So please take a moment to answer the pre-survey question and rate your knowledge on your understanding of the Maryland Primary Care Program framework. I'm sure we're almost 10 months into it, so a lot of us, I guess, are pretty high, but who knows? You may walk away with a thing or two at the end of the session. Okay, so we'll start this session by playing you this short video clip. I just want you to understand the importance of knowing why we're doing this. So I think this video clip would kind of say it all.
So you're a musical director?
Yes, sir.
All right, so let me get a couple bars of like Amazing Grace. Can you do the first part of that? Go ahead.
Amazing grace, how sweet the sound that saved a wretch like me.
Wow. That bro could sing. You know what I'm saying? All right. Now, once you give me the version, it's if your uncle just got out of jail, you got shot in the back when you was a kid. I'm just saying, let me see the hood version real quick. If you know which version I'm talking about, just see if that exists. Let me see what you got.
Amazing grace, how sweet the sound that saved a wretch like me. Right now I'm found, was blind, but now I see.
So here's the thing. The first time I asked him to sing, he knew what he was doing. The second time I asked him to sing, he knew why he was doing it. When you know your why, your what has more impact because you're walking in or towards your purpose.
So let me give you a minute to take that in. So we want to start with discussing why. Why are we embarking on this transformation journey? Because if we know more about the why, then it just gears you up and you are powered up. So the first reason is that we want to provide the best quality of care for all Marylanders. The second is that we want to shift from an ever-increasing volume demand to more value-based care. We also want to avoid unnecessary ED visits and hospital visits. And then we also want to show the nation that we can be a leader in healthcare. And to bring back the vision of what primary care used to be, we will share this iconic picture. And this is a picture that was painted by Norman Rockwell back in the 1940s. And this is his doctor, Dr. Russell. And back in the day, the doctor meant more than just the physician. He kind of knew the family. He talked about what social concerns you had, and he spent time with you. So we know that times have changed, but right now, we're trying to go back to what primary care used to be. So hopefully, as we embark on our primary care transformation journey, we can at least have an idea of what the vision is as we move forward. So why primary care in particular? One, we have international experience that this is a good idea. We know that we also have experience here in the United States, and we also have stakeholder input about the total cost of care model when it was in development. And primary care is the single largest provider category and has the lowest healthcare spend and low cost venue for care, and is the best place to invest in if you want to avoid unnecessary hospitalizations and ED visits, and also to offset the burnout of PCPs. Now, I'm not just saying this. In the next couple of slides, we'll go into the facts, what research shows, so you know why it's important for us to invest in primary care. So looking at this slide here, most people have the illusion that America has the best healthcare. So people come from all over the world to Mayo Clinic, to Cleveland Clinic, to Hopkins. But objectively, the World Health ranks the US number 39. And this is amongst other countries that are economically developed as we are. So you can see Sweden is up there, Norway, Iceland, Japan, and we are right here at 39. Now you would expect, okay, well that's one picture, one side of the conversation, but we look at the spending, how rich is the country compared to how much they spend in healthcare for each person. So if you look here, you can see that United States is among the top 5 richest countries in the world. And look at our health spend. So we are right up here, even though we're the 3rd or 4th richest country in the world. We spend up to $10,000 per person per year in healthcare, compared to Luxembourg, Switzerland, Ireland, Norway, who are just about as rich as we are. So this is something to consider, that we spend all this money, and the question is, what are we getting for the money we're spending? Now, the US life expectancy is an indicator to know generally how healthy the country is. And you can see the light blue bar here is the average, again, amongst economically developed countries at 82 years. And the United States is right there in the bottom, 78. And this has been declining over the years. If you look again at another indicator, disease burden, it's also called the DALYs, which is disability adjusted life years. And what it actually tries to present is how much you would have been able to improve your living if not for having a disability. So you want that number to be small. And as you can see here, the average is 18,000 days, but the US is right up there at 23,000. So again, we're spending all this money, but we just saw now that we're spending more, but we are not, our disease burden is higher compared to other countries. And then if we look at the ratio of primary care to specialists, this gives us a clue as to why this may be so. If you see the United States here, 12% of our physicians are primary care, and 88% are specialists. This is so different from countries like Canada and France. It's almost about a 50-50. So it's a clue. Maybe we're not making the right investments in the right places. Now, we've talked about the international perspective. Now, looking in the US, Rhode Island did some pilots, and this was published in Health Affairs early this year. And they chose to spend more, invest more in primary care. And as you can see, they saw a reduction in cost, total cost of care over time, and also in healthcare outcomes. So again, another clue. Another publication Earlier this year was done in the Journal of the American Medical Association. And this is an experimental model, but if you look in this red box, what it's trying to say is, if we increase the number of primary care providers by 10 for every 100,000 individuals, we will increase the life expectancy by about 50 days. So knowing that our life expectancy is declining, and we have an idea of how this could actually improve by investing in primary care, again, gives us another clue what we should be doing. So because of all of this, the leaders came together, both state and federal, and said the state of Maryland can do something differently. So the total cost of care model agreement was signed July 9th, 2018. And this was with Governor Larry Hogan, the head of the Senate and the House, and federal dignitaries. And the whole idea was, how can we improve our investments in healthcare, particularly primary care, to improve healthcare outcomes. So this is the total cost of care model. How many of you have heard about this model? Good, awesome. So just a quick overview. So it has 4 key components. The first one is the hospital PBR, population-based revenue. And here, hospitals were challenged with reducing costs over 5 years for Medicare Part A and Part B in both ambulatory and inpatient services. For the care redesign, you have partnerships between hospitals and different providers to see how they can better coordinate care and transitions of care to reduce cost. The third is population health. And in this instance, certain disease burdens that's caused by diabetes, hypertension, can be taken on by states with the goal of reducing the incidence every year. And you get credit for it towards the total cost of care. Well, the state of Maryland is starting off with diabetes. So if you hear about a lot of diabetes program there, that's what we've chosen to start with. And then we have MDPCP, which is at the core of it, because here you see everything has to be centered around patient-centered care, but we know that that starts with the primary care physician or the primary care practice. So here are the requirements. So the primary care functions for the Maryland Primary Care Program has 5, across the 5 different primary care functions, you now know, is access to continuity, care management, comprehensiveness and coordination, beneficiary and caregiver experience, and planned care for health outcomes. Now, a lot of us have been in this long enough to already know the components of this. I'll just breeze through this. So for track 1, you have, for all tracks, you have to empower your patients, and you have to have 24/7 patient access. And then for those in track 2, you are required to have alternatives to traditional office visits. I will say that I've seen track 1 practices who already have that. So again, you don't have to be limited by the track you're in, as long as you know this is something you can do and it's going to improve care transformation, care delivery across the board for all your patients. Then you have care management, where you have to focus first on risk stratifying your patient population. So you identify the sickest of the sick, and you're able to assign resources that they need to have a stable health. And then you have short and long-term care, also known as longitudinal and episodic care management. And then follow up on patients who were recently hospitalized or had an ED visit to understand what the transition of care needs might be, again, to help keep the patient's health stable. You also have to have care plans, especially for patients who are in longitudinal care management, to identify what are the care they need immediately and put it into a plan that's kind of coordinated both with the social intervention plan that will be done by the CHW as needed, as well as with medication management. Did I go too fast? Okay. And then the third is comprehensiveness and coordination. You have to coordinate referrals with high volume, high cost specialists serving the population. You would see this on your CRISP dashboard on the CRISP portal, MDPCP dashboard on CRISP portal. And when you do identify these high volume specialists, the goal is to develop a collaborative with them to discuss how you can best manage your patients. Something also important here is to integrate behavioral health. Now, behavioral health has been hard to do because you have limited resources, and it wasn't easy to come up with a plan on how to do this. But with the MDPCP program, we do have both. So hopefully, it's a work in progress, but hopefully we can keep working at it. But now it is just as important, especially because in the face of the opioid crisis, which claims about 2,000 lives in the state of Maryland every year. You also have to facilitate access to community resources and support for social needs. Now, let me say that even though this is a requirement for track 2, nothing stops you as a track 1 practice to see that this is stopping you from accomplishing other goals. So if the patient needs transportation support and community resources can help take care of that issue, well, I don't have to wait to be track 2 to fix that, right? Otherwise, I cannot get my other requirements in line to support the patient. Okay, we have the beneficiary and caregiver engagement. As we know, talking to a patient in the exam room while they are sitting on the line or sitting on the examination bed and they'll have a paper gown is not the right time to ask them, how am I doing? Because I'll tell you, I'm doing wonderful. I just need to get out of here and put on my clothes. So the PFAC is trying to have that environment that makes the patient and their caregiver comfortable to share what they think should be done. You have to create an environment. If the physician being in the room is a problem, they don't have to be in the meeting, but give them a chance to speak their mind. Be open. They're not trying to criticize you, they're just trying to tell you. And you need to find out how you can incorporate the feedback to improve the way you deliver care. So we have a session on PFAC here, and I'm sure some of you have already started that. So it would either just support what you're currently doing or give you more ideas of how you can improve on what you're already doing. Also, we encourage advanced care planning when needed because that helps save costs. Again, we are going to discuss that later on. And then the last primary care function is planned care for health care outcomes. And this is pretty much just trying to tell us to focus on continuous quality improvement. We'll talk about CQI. We'll do a little deep dive into PDSA, how to do it for those who haven't started, and just how do you change the culture to improve quality. So the 2019 matrix, as you know, because the report came out recently for the ECQMA reporting, 50% will be on quality and 50% will be on utilization. So for quality, we have the ECQMs. You're supposed to focus on diabetes and hypertension control. For those of you who have already done this through HEDIS, this is not new. And then the new one added here is also screening and initiation of treatment for substance abuse and NQF 0004. Again, this year is just to report that the patient was screened and at least something was done. They were referred, right? In subsequent years, more details about the what or how the patient was cared for might be taken into consideration as a requirement. But right now, just reporting at least is what is required of the practices. Then also patient satisfaction. I was hoping to skip over this one because the patient roster exercise didn't go over too well, but I promise you the state and CMS are working hard to make sure that doesn't happen again. But I'll also say there was an eye-opener. It really tested the relationships between practices and their CTOs for those who had them. So the mixed feeling, and for those who were able to lean on their CTOs and the practice coaches from the state, at least they got more direction, guidance, and support. So in times like that, please use or leverage your resources. But again, I just want to share with you behind the scene that work is being done, that you don't have to go through that difficulty next time. And then utilization. Emergency department visits and hospitalization per 1,000 is also a HEDIS measure, so should not be new. And again, remember that this is going to be done for all patients and not just the patients in MDPCP. And I didn't get a question today about that. However, in the past, this is the fifth the fifth training in the series of training we've been doing, and folks had that frown in their face like, okay, I'm not understanding. You gave me money for 10 people and you're asking me to account for 1,000. But the whole idea is if you start implementing transformation in your practice, somehow it kind of spreads across, right? Yes, go ahead.
We'll get to it.
Yeah. So he was supposed to help us do that. Please help me remind him to come. Sorry. Yeah. Yeah, but do you have this slide? Do you have the slide downloaded as well? That's just an interim solution while she checks in with him. I think he just needs to move this. All right, and then the resources that you have to support you in this program include the CTOs, the Care Transformation Organization. As you know, they're supposed to provide you a number of services and staff to support that. But I want to fast track to this slide that, you know, like they say, the devil is in the details. So if you have the CTO arrangement or agreement, make sure that you inform every single person in the practice about this. Because, for example, if you have your MA trying to work to improve on, for example, alternative care, maybe she's thinking about a telephonic visit, she needs to support the physician to schedule or coordinate. I mean, she can already know that the CTO has offered to provide a CHW for home visits. So, hey, the patient's a no-show. Where's that CHW? I need her on speed dial just to say, hey, we've been trying to locate this patient. You know, they recently had a recent ED visit, so we think that this is an episodic need here. Is there a way we can locate this patient besides just having no response when we call? So things like that. And for those who are office managers or working QI, you also see here population health management analytics. In this example here, the CTO was supposed to target and track performance on required key outcomes monthly, quarterly, and annually. So if this CTO has said this here, then hold them accountable to it. Make sure you go and say, hey, you know, when do we, you know, have this set up? Do you have a, you know, somewhere on your site where we can go have it, or on our site? Do we have monthly meetings or weekly meetings, bi-weekly meetings to check on this? Or do we just review what's on the CRIS portal and what else is not there that we need to have as interim reports to inform what we're doing at a more granular level? So again, please look at the arrangement, look at the agreement so you know what resources are available to you and you can use them. And then existing resources with CRISP include the Maryland Prescription Drug Monitoring Program, the ENS Encounter Notification Service for, you know, in real time where your patients are when they go to the hospital, the query portal, as well as direct secure messaging. Additional services include quality measures reporting to CMMI, hospital and ED utilization data, and specialist cost. I think in October you will have a risk stratification tool that will be available to you to use. Some of you already have risk stratification methodologies you've adopted. Some of them are configured in your EMR. Again, it's up to you to choose what you want to do, but at least you can look at the tool and see if it meets your needs better than what you currently have and make the change. Also, other things coming up would be a social determinant screening and resource directory, care plan and clear alerts. Some practices have started working on this with CRIS as well. We will have a CRISP representative for session 6, I believe, here to discuss in detail about all the different resources they have for those in the MDPCP program, and you can ask follow-up questions. So you also have the MDPCP learning system. So you have the practice coaches, state and CTO. Any practice coaches here? I'm trying to. So yeah, so they're the first line of defense. If you have a question, right? Question, I said. And then you have the training academy. This training we're doing that's more hands-on. You have webinars, office hours, online manuals. You have collaborative communities on Connect. I'm sure you see they have a risk stratification group, a group of small practice groups for those who are very small size and things like that. Care management, I think, is another collaborative communities. So use that. You have newsletters to kind of tell you what's coming, what's currently happening. You have 3 annual face-to-face meetings. How many of you have attended any of the face-to-face? Yeah, it's far. So they've had 2 so far, so 1 more to go. Again, take your time. If you can attend, that would be nice. If you can't, send a representative. Or if you, again, we did the high five. So you see her there said, I did go. So hey, what was new? I hope she found something new to share, but yeah, so things like that. So here's a picture of some of your practice coaches. Some folks joined after this slide was created, so in case you don't see his handsome face, he's on here. He's TJ. So please, again, our practice coach is assigned to each of the practices. And for those who work with CTOs, yes, you still do have a state practice coach assigned, but they probably work mainly through your CTO, but you should still get to know who they are. So if you need to reach out to them, you can. In program year one, about 590 practices applied to be in this program, 380 were accepted. And with that, we have 220,000 Medicare fee-for-service beneficiaries. Now, about 150 practices applied, so this might go up to 250,000 by 2020. 1,500 primary care providers. This may go up to 2,000 by next year. And then about 21 care transformation organizations. 3 new CTOs were approved this year, so about 24 will be participating in the program in 2020. And as you can see the breakdown here, about 78% of the practices are working with CTOs, another 9% working with CTO-like groups. So, well, almost 90% of practices in the program are using a CTO or CTO-like group, which is great. So when the CTO was established as a new entity, some called like an ACO, but different. The whole idea was based on lessons learned from CPC Plus, the national version. Physicians felt like you just don't throw money at the practice, both all practitioners, so physicians and nurse practitioners, so you just don't throw money at the practice and expect things to happen. We still have to figure out how we incorporate transformation into our schedule so that we don't, lose patients or time or revenue. So because of that, the idea came up to why don't we set up a care transformation organization that will be an extension of the practice. So if they need to lean on resources to support them through transformation, they can do so. And for those who feel they don't need it because they can figure this out by themselves, or they've been performing in ACO, participating in ACOs prior to this, then they can do so as well. So again, it's optional because we just want to meet the practices where they are. So here's a map to show the distribution. And I know that this is, not a lot, but I would say that the FQACs have been going through some review, and they will hopefully join the MDPCP program in the next 2 years or so. They just have to do some walk around, so we're double dipping. So you get to see more red dots here. So circling back to this painting, and the only thing we photoshopped in here is computer. He's not looking at it, but so let's try to leverage electronic medical records or health IT. And know it has brought on its own complexities, but it has also been easy to access data and patient information. So our goal in MDPCP is to make sure that we leverage more of the ease to use health IT and stay away from the complexities of it. And I think we can do this together, but looking at this vision of having that, feel good relationship with your physician because they really know you and understand what makes you a holistic well-being is important. And hopefully in our transformation journey, which will not be today, this program is for 8 years. It may take that long or longer, but as long as we're making strides slowly but surely, I think we'll get there together. So I want to end with remembering the why. So this is a famous quote by President JF Kennedy, and he said, "We choose to go to the moon," and I'll paraphrase it here, "we choose to go to the moon in this decade and do other things not because they are easy, but because they're hard and because that goal will serve our purpose." That challenge is one that we're willing to accept, one we are unwilling to postpone, and one that we intend to win. So remembering the why, we know that our healthcare system can be better. We know it starts with us in the primary care setting. So we here have accepted that challenge, and we intend to win together. So that ends this session. Please take the post survey. And then we have a quick 5-minute break and come back for the next session.